Good morning, everyone, and we're very happy to have you with us tonight. So throughout this webinar, do not hesitate asking questions using the Q&A box or the chat, and we will pick up some of them and ask them to the speakers. Adela, this is your turn.
Thank you, Doctor. Good morning to everyone. My name is Adela Perola, and I am a hematologist working in Tirana, Albania, at the University Hospital Mother Teresa since 2006. And this is a great honor to be with you this evening. As a hematologist, I face the relentless demands of our profession and seeing the toll it takes to not just on myself, but also on my colleagues. And driven by this experience, I initiated a research project on burnout, and upon submission of my paper to Hemasphere, the editor suggested that I collaborate with the YoungEHA. And so taking this advice, I reached out to Dr. Combaumier and colleagues who were equally passionate about addressing burnout. So our discussion sparked a larger initiative, the Burnout Project, and evolving so from a mere publication to a full-scale evaluation of burnout among European Hematology Association members. Thank you, Com.
Indeed, Adela. There is no shame to recognize that hematologists failed to tackle this issue in the past. While many papers were published in general medicine, in surgery, in oncology, intensive care, psychiatry, or pediatrics, there is no such evidence existing in hematology. Along with the YoungEHA and the Young National Society ambassadors, we endeavored to survey the EHA members about their burnout symptoms and the factors that may cause them. This survey will be promoted during the EHA Congress in Madrid, thanks to the invaluable support of the EHA and its former president, Elizabeth McIntyre. To raise the awareness on the topic, we invited tonight two of the greatest burnout experts in intensive care unit and oncology, who will be introduced right now by Elizabeth. Thank you very much. Elizabeth, you're muted.
Thank you very much, Com, and I'm doubly delighted to be here. First of all, as ex-EHA president, also as a French practicing hematologist. I'm Scottish and French, but I've worked in Paris for the last 30 years. And when Com mentioned this project to me, I was absolutely delighted to suggest that it be rolled out, and I'm glad to see that that's been the case. I'm currently having finished the EHA presidency, I then became president of the Biomedical Alliance in Europe, and I can confirm that these kind of issues are across the board, and they're certainly in no way specific to any specialty. So I'm delighted to have two such well-recognized speakers in this field joining us. We'll first of all be listening to Elie Azoulay, who I will present formally in a second, and we'll take questions straight after Elie's presentation, because unfortunately, partly because of time differences, our second speaker, Tate Chanavert, will be online. So but first of all, I'm very, very happy to have Professor Elie Azoulay, who's a full professor of critical care medicine in Hôpital Saint-Louis, where Com works, where I used to work. He's also the president of the European Society of Intensive Care Medicine. And then in addition to being a very brilliant intensive care academic hospital specialist, he's contributed very significantly in leading important research studies on burnout for at least the last 15 years. So tonight he's going to ask us a troubling question that I feel quite comfortable with, because I did have burnout 15 years ago, and I came out of it much, much stronger than I went into it. So it's a double pleasure to be here 15 years later, because tonight Elie is going to ask us, are you burnt out? So over to you, Elie. Thank you.
Thank you very much, Elizabeth. Thank you, Adela, and thank you, Com. I'm sharing my slide. I just want to thank you for the invitation. I'm not a hematologist, but I live in an environment where hematologists are there almost every day. And I would like to say how much I'm grateful to Biomedical Alliance and Professor McIntyre, because we applied for a European project that is called Resilient, and the Biomedical Alliance was very much supportive, and I really appreciated that. So, are you burnout? And that's not a joke. I'm going to report on a case that happened quite recently. One of our nurses, well, he texted the head nurse at 5 a.m. saying that he worried about a patient and he probably won't be there this day. 5 days earlier, he surprised everyone by being very cynical. He was saying that the patients were condemned, that everyone will end dying. A bit earlier, he sent an email at 1 a.m. to complain that he was the only one committed at high level. So you can see that things are not so cute, and that many days and even many weeks before the big trouble, already we had alarming signs. Everyone says that Benjamin has a very nice personality. He is very highly demanding and very rigid. He's single, he doesn't smoke, and has recently stopped piano because he had no chance to be good. As colleagues, as hospital leads, as decision makers, we need to sit, think, and understand what is happening. Recognizing burnout is not something that is restricted to specialists, to psychologists or psychiatrists or occupational medicine. This is a commitment for everyone. We need to understand that those people have a battery at 1%, but they are still here. They feel overwhelmed. They are unable to meet constant demands. They are very vulnerable. You are facing people who are completely dehumanized, helpless, hopeless, and completely worn out. Your attitude needs to make very clear that you need to understand what is happening, the setting, the story, what happened the days before. You need to ask the head nurses, the colleagues, everyone in your department, and understand whether you're still at a stage where you can reverse. The basic principle is, as far as the person is still here, you can reverse. You need to reverse at an individual level, but also at a collective level, because burnout is very contagious, maybe as much as COVID. You need to rule out differential diagnosis like you do in medicine every day, but in a setting that is not completely your specialty, and you need to avoid contagion. So this is what is happening. You are speaking with Benjamin, and this is what you can hear. He's complaining, but without saying that he's complaining, that he has no control over his work, that his work is very monotonous, that he is not enough rewarded. And you can see that he works in chaotic and high pressure environment, and you have different signs. So you need now to put everything in order. And this is very helping. You need to understand what is related to emotional exhaustion, what is related to depersonalization, which means that you don't recognize the person, and what is related to a feeling of reduced personal accomplishment at work. These three domains exemplify burnout. The people feel overextended. They are depleted. When you're stressed, you're full of commitments. You still cope, but you are full. When you're with burnout, which is a chronic stress, you really feel depleted. You're exhausted. You're discouraged. At the same time, people don't recognize the person you were. You're cynical, you're negative, you try to take distance, you lose motivation, and you're almost dehumanized. And then sometimes you also feel that you have a reduced perceived efficacy and a feeling of incompetence. But that, I would say, for this third domain, not only it's not mandatory for the diagnosis of burnout, but also it depends a lot on where you work and what is your personality. It's not something from today. More than 60 years ago, these researchers, they were both sociologists, they reported on a new nurse in the psychiatry world that was really contaminated by burnout a few weeks after having started. So if you work in a chaotic environment, if you work in a very poor ethical climate, you can really get burnout in a few weeks. It is very contagious. The impact is of course, for the patients. Patients and their family members are much less satisfied when there is a high level of burnout in the departments where you are. This has been shown in intensive care units, but it is also true in emergency department and in oncology department. Interestingly, when you look at an individual level, the consequences of burnout, you can see that there are many things related to sleep disruption and insomnia. So you need to pay attention to that, but also to many behavioral things like spending too much money, having eating and drinking problems, maybe sometimes addictions, and of course, a bit of depressive symptoms. But burnout is defined as a non-depressive state. This is a paper from a nurse working in California, and she has really shown the relationship between workload and burnout. And this is why we are keeping our time fighting for our ratios. The ratios is for each time you are adding a patient to a nurse, you are adding patient mortality, but you are also adding nurse burnout. So this is very important for every day when someone is in a hemato-onco emergency or ICU department. This is a study that we did a few years ago that made a lot of noise in France. And Tide, by the way, was very much helping to do this study. It's a study in professors in France. For many different reasons, there was a very high level of burnout, almost 50% of the tenured professors, where everyone would think that they are spared and they are very much in situations where they would never face themselves burnout. And when you can see the consequences of burnout, this is very serious. It's about regretting the career. It's about feeling to leave. The job leave intent is very important in people having burnout. It's about personal and professional life. But we know that it has a very high potential for creating a poor ambience in the setting where we work. A bit of history. Burnout has been described almost a century ago. And I really recommend this book from Thomas Mann, Burnouts, where he really describes an extreme fatigue and loss of idealism in a worker. In the 60s, there was also a very nice case of burnout reported, but at that time, burnout was used as something like a declarative thing, but it was not a diagnosis. It is a diagnosis since a psychiatrist, Herbert Freudenberger, who is German from his origin but worked in the US, and Christina Maslach, an amazing person, and very helping. If you are working on that, you can contact her. She's always here and always helping, and she's a professor of psychology. And they described the disease as, from the psychiatrist's view, an emotional depletion, and from the psychological view, an occupational thing. And you can see that since then, the number of publications on burnout is very important. One of the problems at that time is that burnout was considered as a social problem. When you say social problem, it means that you are not looking for a solution to it, and you are not trying to address that. So this is why, for a long time, burnout has been described, risk factors for burnout have been reported, but very little has been done to prevent and to mitigate the symptoms of burnout. This is how Freudenberger described the disease, and this is why the concept of burnout, burning from the inside, has been very famous since the 70s. And what he describes is a fire, an internal fire that consumes people and leaves them with an immense emptiness. I think that when you have the image in your mind, you understand what people feel. And this is very important to keep in mind when you are facing someone with burnout, because it helps you avoiding a lot of words, a lot of behaviors, and a lot of things that you should really not say when you see them. Now, I would like to emphasize how much important is thinking about the trajectories of burnout. Burnout is not something acute. What is acute is the stress, and burnout is a prolonged stress. When you say that, you understand that it is preventable because there is a time where a threshold moment where you can really act and avoid burnout. This is a drawing that we published in the Critical Care Journal, where you can really see the difference between chronic stress, where you're still there and there is still light, and burnout, where you're not there anymore and there is no light anymore. Again, you have signs of alarm, and each time you assess a case of burnout, you can see that then people made their best to resist, and then they became exhausted. I really want to insist on that. Freudenberger reported that as 10 states. It's not very important to understand what are the different states. It's just important to understand that it takes weeks and months before really becoming depleted and exhausted. Look at the left part of the slide, and you can see that there is a trajectory. So each time you need, as a hospital leader, as a team leader, you need to understand where your department is, at which level you are. You are certainly somewhere, and you need to do something, and we will speak about that later, on how you can reverse. Because as far as you are conscious and you are aware of the situation, you are able to reverse. The difference between stress and burnout. So stress is acute, but stress is a feeling that you experience too much pressure. Burnout, nothing is enough. You feel really empty and depleted. You are hopeless. You are burned. It's very different. Again, no one will come to you to complain about burnout. You will see that the stress people have the stress face, and you know that when you meet someone, you can see whether he or she is stressed. But when someone is really burnt out, he's not there anymore. He's on leave and he will never come back. Or we should do everything to find the right place for her or him to be sure that the person is safe. No one will complain about burnout. Everything that is written here has already been said. But the important thing is that it's not a symptom, it's not a syndrome on which we complain. When you are at this stage, you are living and you are on leave. If you can still complain and if you express feelings of burnout, so then maybe it's more transient and we can still act. So these are the faces of people experiencing and feeling burnout. A very important sign that you need to pay attention to is that when people work, they want to sleep, and when they are at home, they think about work. And this paradox is very much, I wouldn't say a signature, but I would still say that it's very classic in people experiencing burnout. Now, let's try to understand what leads to the situation. It's mostly about hectic work. Well, actually, people work in a chaotic work organization, and this is very much reversible. This is avoidable. People are busy, and we need to understand how we organize. Maybe we should assign patients according to workload rather than numbers. And people feel overcommitted, even if they are not. This is what they feel. And this leads to burnout. I would like to mention something very important, is that it's not related to the personality or to the lifestyle. Many people from many different personality would not experience burnout if they live in an environment that is ethically acceptable and where the ambience, the climate is good. Again, citing Freudenberger, you need to understand what is related to the working conditions and what are the efforts that you need to make with your team to go back on that and work on that. Whether you cannot meet people's expectations, and then you need to make clear what are the goals in your departments and what people can expect as healthcare providers, healthcare professionals, And then work organization, where we can always do something unless you have an internal conflict between different professionals. So looking at that, we know that we can act on how we organize the work, how we can communicate with people to let them understand what they can expect from the work and what they should expect from other settings. And then we need to also organize the work. And for that, in many departments, working groups are set to work on that and to avoid these feelings of burnout. Another very important thing, and this is the reason why we need to be helped by a psychologist or an occupation specialist, occupation medicine doctor, is that there are many different symptoms in our healthcare professionals that really mimic burnout, but are not burnout. It can be, for example, moral distress when you deliver a care that is not at odds with your own expectations. It's about post-traumatic stress disorder, and you need to understand that sometimes we live in an environment that can be associated with psychotrauma. It can be depression, but then there is a conceptual difference. So we need to be helped to be sure that we are actually addressing burnout. This is a study that we did in healthcare professionals in France who were facing the COVID-19 surge. And you can see here, there are 45% of people meeting criteria for severe burnout, but only 10% of them have only the symptoms of burnout. Otherwise, they also have anxiety, depression, and post-traumatic stress disorder. So this is something we need to think about when we address that. It's very unlikely that if you take burnout as an entire system, an entire syndrome, you can address that without addressing the other symptoms that have different determinants. So being helped for that, so we did a cartoon, and of course I would be very happy to deliver it for free to everyone at EHA. This cartoon has been translated in English, and it's a cartoon that reports a situation on burnout at the workplace. But it's also a cartoon where we did a lot of efforts. So Olivier Lescal is the drawer. He was actually my chief resident a few years ago. Now he's a medical drawer. And we paid a lot of attention to other symptoms and to differential diagnosis that can sometimes have the same determinants. Again, we need to, when we face our teams and when we want to speak about people's expectations, we need to help people understand how to cope with the pressure. And there is a kind of balance that we need to find. And every department, every group, every individual has or have their own balance. So we need to find whether in this specific group we can avoid burnout without going into situations where people are in situation of frustration and they are bored out. So this is very important to find the balance, and there is not one balance. One side doesn't fit to all. Every department, every system, every people, every country have their own balance. This is a study from the next speaker, Tatjana Feld, who is a worldwide leader on burnout and also someone very, very nice, always helping and always making nice comments on the papers. And this is an important paper because it's a comparison of burnout prevalence across different specialties. And as mentioned by Com earlier, there is very little on oncology and hematology. There are still things, but not at that time. One thing that is important is to use the right operational definition of burnout. And I really recommend that you use one specific instrument that is called the MBI, developed by Christina Meslash and Jackson, another colleague. And they did studies on burnout using the MBI, the Meslash Burnout Inventory. This study made in US hematologists and oncologists had a very low response rate, 25%, but still they reported that 1/3 of the respondents experienced burnout. And interestingly, the risk factors for burnout were exactly the same than in other studies. But here there was also an influence on whether it was a public or a private medicine representative. This study did not use the MASLASH-Burnout inventory, so I recommend that for your European Hematology Association survey, you use the MASLASH-Burnout inventory. Interestingly, so they ranked the burnout as either mild, moderate, or severe, and you can see that the consequences and the experience, like about career development or the wish to leave and to change the job, were very much related to the severity of burnout. This is another study that we published during the COVID-19 pandemic, and I just want to show you that to make clear that if you are surveying different countries, you also need to get information on the characteristics of those countries, because it's very important to understand that there are local determinants that you cannot control, like, for example, relationship between nurses and doctors, behaviors, work organization that is imposed by the systems, etc. So if you do that, you need to have center characteristics that will help you to understand this variability. The same people exposed to the same strain might develop burnout in different proportion, and we need to understand that. So if you do a study in different countries, this is another very important thing that you need to collect them. So this is the French version of the MBI. It has been translated in 17 languages. The English version is very easy to understand for a doctor, a resident, a fellow, or anyone. So the English version can be used. So the 22 items are very easy to complete. It takes 12 to 15 minutes for a doctor. And very interestingly, it depicts exactly the 3 domains of burnout: emotional exhaustion, depersonalization, and personal accomplishment. As I told you, to define burnout, you would only use emotional exhaustion and depersonalization. You would not use the personal accomplishment anymore. That was done previously, but not anymore. We are only using the 2 first domains with validated thresholds to define severe or moderate burnout. So this is a study that we did in ICU specialists in France. 50% of them experienced burnout. And this is a study in nurses in France, and 30% of them experienced burnout. And burnout were mostly related to conflicts, professional conflicts, with the family members, with the patients, with other nurses, with the doctors. So again, communication and the ethical climate in a department are very important to address to avoid burnout. Now we are looking at the second part of the same figure, which is how we can build resilience. Because dealing with burnout includes the 3 R's: recognize, reverse, and build resilience. I'm going to go very quickly on this last part. Developing communication and promoting well-being is really something on which, as hospital leaders, we need to be trained, and we need to help each other, because it's not something so natural, and we need to speak to each other to say what we did and how we can collaborate together. There are very important landmark actions like developing self-awareness, self-regulation, motivation, empathy, and social skills. And this is something you can learn in 1 day. 1.5 days for residents and 1 day for senior doctors. It's very easy. And when you go back to your work and people rank you for these different domains, you really improved. I think we should do that every 2 years. If we develop leadership and empowerment, we are also able to significantly reduce burnout. This is an ICU study. But clearly, we also need to speak with the nurses about the appropriate level of care, whether we should include palliative care specialists, whether we should discuss more with the patients and giving a lot of importance to patients' preferences and values, to the family members, but also to healthcare professionals. So everything about communication is really able, it can allow you to really prevent burnout. This is a communication study. It's a before-after trial where these researchers were really able to reduce burnout after the development of a communication strategy. And interestingly, when you look at the different components in terms of communication, it's again, we are looking at the same processes. So we need to work on the context, on the organization, on the relation, and on the different processes that we need to develop in every place. I think that things might be common for some department, but for some others, we need to really develop things that are adapted to our setting. And lastly, there is, of course, mindfulness and many different behavior interventions that are also allowing to reduce the feelings of burnout and the symptoms of burnout. The last part of my presentation is mostly for the slides. So you will have the slides and you will look at that. It's about promoting actions. We are here having the European Hematology Association. I'm the president of the Intensive Care, European Intensive Care Association, and Professor McIntyre is the president of Biomedical Alliance. So we understand that we are committed to have actions and to really need to make calls for actions to really reduce burnout and moral distress. There are calls for actions in hematology, and this is a recent editorial in the Lancet Hematology that is very nicely written and also addresses that. And it's also on the website of the ASH. So I'm very, very happy that for the European Society of Hematology, this is something that is gaining recognition, and developing well-being and resilience for everyone in our departments is really important. I'm just showing you that because it's very important to conclude that, to my view, burnout is not a fatality, and there are many actions that can allow you to not only recognize, reverse, and help people build their resilience. Thank you very much for your attention.
Thank you very much, Ellie. Elizabeth, maybe you have something to say?
Thank you, Ellie. That was a wonderful presentation, and I'm delighted to hear that it's going to be recorded and available on our website, because I'm sure some people would enjoy stopping it when they want to look at a slide for longer. You were each given 20 minutes for to talk, so I think we've got a few minutes to take some questions from you. Do you have questions coming in through the chat box? I have them, but
so waiting for people to write some question down. I have a few one. You explained very well the differences between, I mean, that burnout is not always what we think it is. And for example, how to make a difference between the burnouts and what we could call the self-defense against difficulty, against death in our daily life. Because you can share the same behaviors, and sometimes it will be like self-defense, and some of the time it will be burnout. How do you?
Com, you're addressing a very important point about coping strategies. Coping strategies are actually helping you to address. So you are facing, all of us will face the same, trauma or strain or conflict or difficult situation. But according to many different things, and mostly coping strategies, we are going to develop A, B, C, or D, or nothing. So these coping strategies are related to how we have been trained. And oncologists are much more advanced than us for the training. There is a lady in London working on that, doing trainings that are lasting 1.5 days, sometimes 2 days, improving communication, improving coping strategies, and helping people to really address what they can face. And this is not self-defense. This is a way to accept what you see, but not taking it personally. This is something we can learn. It's very easy. Role-playing and simulation are very efficient for that, and it has been recently developed with the European Society of Intensive Care Medicine. We are having a huge program on preventing burnout, and we would be very happy to collaborate and work with our young colleagues, hematologists. We are doing fellowships on mental health. So, for example, and this is a cartoon that we are doing with the European Society, where we train people to understand the different symptoms, the different things that can help them recognize. I think that self-awareness, but also awareness to colleagues and everyone in our department is the best way to prevent burnout and to reverse the most difficult situations. When it's too late, it's too late.
Ellie, you could perhaps make a good argument for making it an obligatory part of specialist training.
Yeah, I think that it is already the case. It is recommended that the call for action that has been, well, it has been written by the European Society for Intensive Care. It has been written by many different societies. By the way, Biomedical Alliance could also be the one claiming for that, because you have a very big impact being yourself the consortium of many different teaching societies. I think that when you go to countries and you say you should, it doesn't work. When we train people, when we, you know, with all the social media, with all the things that we can register, we can record, I think that very simple things can attract people and can help them really develop specific skills for that. But we need to be helped.
Can I just ask one very quick question? What is the incidence of burnout using the MBI scale in the closest to a happy general population? Because it's not going to be zero, is it?
No, it's 9 to 10%. It's 9 to 10%, yeah.
Okay, and are healthcare professionals the highest professional group in that, on that,
So
most prevalent?
pediatric, emergency, intensive care, oncology are above 50%.
But healthcare professionals compared to footballers or governors or...
No, the GAFA, for example, Amazon, etc., there are 70, 75, 80% of burnout. So it depends who are the control. Yeah, the GAFA are at a very, very high level for burnout. But I don't know for footballers. I don't know if it has already been assessed. Maybe, I don't know. But there is also a very large country variability. And as you know, there is a very, very big difference between men and women. And it's not about claiming that you're having symptoms. It's really something about the vulnerability. And our systems need to become more resilient for our female colleagues. And we do efforts, but we are very far from the target.
Adela, do you have any question?
I have a question for the professor about how can you please suggest how can you access the other way of managing in different clinics? Different clinics have different ways of managing the situation. How can we access this? Because
I think that this is a great question. There are things that are common to different settings and things that are specific to where we are, where you work, and certainly the specialty. I think that if you work in a chaotic environment like the emergency departments all over the world, I think that there is very little that you can do otherwise than training people to cope with the situations. And it works. It works. It works. So this is why those specialties are less exposed to working hours. So if you do 50 hours per week, you can understand that emergency doctors cannot do more than 30 because then they are really burned. And we consider that ED specialists have, in average, a 10-year experience before leaving the job. So if you want to develop specific actions, I think that there are things that are common, like communication, like what we call the ethical climate. So the way you round, the way you involve other people, the way you speak to nurses, to family members, etc. But there are things that are specific, and I think that in hematology and oncology, you have already a lot of things that are done, but they are maybe little used for that. I think that you are, by definition, a very consensual specialty as compared to others, as to cardiology or to other specialties. And I think that this should be emphasized because it's really one of the best ways to prevent burnout. The other thing is the ratio of men versus women. There is a Swiss study showing that if you have more men in your team, you will have more burnout, and we know that. We know that there are if we train people, we would train differently, and this is why simulation is very interesting. We would train differently men and women. And for the next generation, where, as you know, there is a very large number of women doctors, something like about 70% in med schools. So we really need to develop specific curriculum for this. And it's not a shame to say that. I think we need to accept that and to go on and do it, because we know that women are more vulnerable.
I'm just trying to imagine a team with 80% men, then it's probably 100% burnout in the 20% of women.
This is very true. This is a study by Bararikou, R-I-C-O-U, that I didn't show because I had too much slides. And it's a very nice study showing very clearly that if you have a high men to women ratio in your department, you will have more burnout.
Just we're going to have to, we could keep talking a long time, but do you offer, because what I found very positive in your talk is that you can do a 1 day or a 1.5 day training and it makes a difference. Do you offer it through your society? Because I could imagine if we put in 1 day trainings during EHA Congress, I'm sure it would be very popular.
Sure, Elizabeth, this is what we applied for at the European level and with Biomedical Alliance in Europe. So this was a training course where we were upskilling colleagues for burnout prevention. We were also offering hotlines for those who are clearly affected and need support. And we were also offering an online system with occupational medicine and psychology consultation. So we were not taken, but we are going to apply again and hopefully with you. And but still, for now, we would be very happy to collaborate and to develop a system where we would train and upskill residents, fellows, and maybe everyone in hematology departments, at least for those who are interested.
Definitely food for thought.
I would like just another little question. About the economic level of countries, because we are studying the burnout in hematologists in different countries. So Albania, it's a low middle income. Comparing to the high income and other, it will be differences in burnout because we are facing different levels of treatment of the patients. So this could be taken into account when we do the project.
Yeah, this is true. I don't have in mind a study that took that into account when modeling the risk factors for burnout. When we looked at the gross outcome at a country level, it was not associated with burnout, but we had, I would say, very heterogeneous countries, and we didn't assess that properly. So I think that maybe in the study that Comi is leading, that would be something that to which we can pay attention.
Thank you.
I think in the interest of time, and we're going to have to move on, but I think this is hopefully set off further discussions, Ellie. So congratulations to the young.
Thank you.
Thank you for joining. So it's now
Thank you for the invitation.
With great pleasure. So it's my great pleasure to introduce somebody who's, as you've already realized, very well known in the field because he's been liberally referred to by Professor Azoulay. So Tate Shannonfelt is a medical oncologist and hematologist. He was professor at the Mayo Clinic before moving to Stanford University in 2017, where he is Chief Wellness Officer and Associate Dean of the Stanford School of Medicine. In the interest of time, I think you've just realized he's a well-recognized expert in the field, and I'm very glad that we've been able to get him to join us online despite the time difference. So we won't take questions at the end, but if you want to put questions into an email to Com and to and or through the EHA office or to Adela, feel free to do so.
Thank you, Dr. Bormier, for inviting me to deliver this session. and to spend this time with you. I was asked to briefly address in this session what can we do to address physician burnout in hematology and oncology fellows. And I was asked to specifically consider how do individual fellows approach this challenge. And several times through the talk, you'll hear me articulate that that is an important dimension, but probably even more important is for all of us to be thinking about what are the system, work environment, structural interventions that are needed, ideally to be working upstream to preventing physician burnout in the first place and actually creating an environment where hematology, oncology fellows and other clinicians thrive. So acknowledging that, we'll focus a bit on individual approaches today. A couple disclosures just related to some self-assessment tools I helped invent when at Mayo Clinic. Mayo Clinic owns these. They've licensed them for use, and Mayo Clinic shares a portion of the royalties they receive with me, and then also shares royalties related to a book that I'm a co-author on. So the name of CME, just acknowledging these things. We've heard a bit about the prevalence of burnout, other forms of occupational distress in hematology and oncology fellows in the prior session. And when we think about what's contributing to this occupational distress, some of the common variables that are important factors are listed on this slide. I won't list all these for you. They're things that you've experienced or witnessed. These are true for all physicians as contributing factors. And when we think about residents and fellows specifically, there are some additional challenges beyond the ones on the left. We often are moving to a new city. We might be geographically distant from some of our family, friends, and support network. We often are working hours that are more intense and create sleep deprivation to a greater degree. We're developing expertise that is its own challenge and stress. We have debt. We also are starting to think about what comes next after we finish training and thinking about that. So some additional challenges. And the key point on this slide is you'll recognize almost everything on these slides relates to the work environment, the structure of training, workload, and so forth. So these are not challenges created by a weak individual, but are, again, characteristics of the training environment and work environment that are the key problem. Now, just a little bit on hematologists, oncologists specifically. A number of studies have explored the role of grief and exposure to death and suffering in our work as cancer clinicians, and some have suggested that that's a major driver in hematology and oncology. But what these studies have illustrated is a bit of a more nuanced story, that those challenges are a force that can be both positive as well as negative. And so in our personal life, some of the negative consequences to exposure to death and suffering have been associated with changes in our personality, strain on our personal relationships, but that they also give us perspective on life and the things that matter and what's important that can actually be a positive thing and help us make choices and changes that align with the things that matter most. And that professionally, certainly that exposure to death and suffering can contribute to exhaustion and burnout, but also is a source of learning and helps us become more effective in the way we care for future patients going through similar experiences. So again, both positive and negative effects. What these studies also suggest is that it's often our sense of grief at the death of a patient we've come to know and care about, as well as our sense of inefficacy that we couldn't do more, that those elements, more so than just exposure to suffering or death, are what contribute to burnout, and that we can create structural programs in our hematology oncology centers that acknowledge this grief, provide a process and time for us to recognize the patients we've lost, and that can mitigate some of the secondary traumatic stress and be constructive. Now, although we just looked at some of the characteristics in the practice environment that are often the primary sources of distress, there are also some qualities that many physicians have that might place us at risk. And this is really old data from over 30 years ago, illustrating what's been referred to as the clinician personality or the physician personality, suggesting that many of us as physicians have these compulsive traits, that we have a sense of doubt, we have this high sense of responsibility, and that there's a sense of guilt sometimes in our work. And what these psychiatrists and psychologists suggest is that in many ways, we should expect this. Medicine is an inexact science, so we'll always have some level of doubt. We take the trust our patients place in us seriously, so that responsibility is expected. And if things could have gone better for our patients, we often are wondering, what could we have done differently? That doesn't mean there was a mistake. If we're seeing a patient back for cycle 5 of chemotherapy today, and they had excess side effects with the most recent cycle, we'll wonder, could we have done better? Could we have predicted that? Should we have dose reduced? Should we have delayed that cycle? Should we have changed therapy when we saw them several weeks back? And depending on how permanent and severe the side effects are for that patient, we might wonder that every time we see them for the rest of their life. I've often used this as an example. I remember a patient with AML that I cared for as a fellow over 20 years ago, who developed horrendous Ara-C cerebellar toxicity. And, we were obviously evaluating that every day during the treatment, but it developed nonetheless. And that individual was cured of their leukemia, but for the rest of their life, patient has now passed away, lived with that Ara-C toxicity. And so what these psychologists suggest is that in many ways, these are adaptive qualities. You want the physician caring for your own family members to have these traits, but what's a strength for us in one context can actually create maladaptive challenges in other contexts, such as the things listed on the right side of the slide. Now, it has also been shown that another contributing factor for physicians in training, as well as once we get done with training, is what's referred to as the imposter phenomena. None of us love that word, but this is that a condition where we often believe our success is undeserved and due to luck rather than personal effort, skills, and abilities. And this phenomena has been shown to be relatively common in high-achieving individuals who often have feelings of inadequacy and self-doubt despite proof of competence and achievement. This is data from a study we conducted among US physicians in practice several years ago. And what we note is that this phenomena is very common in physicians. When we use some standardized assessments of this phenomena, you see sort of scores here on the x-axis illustrating intensity of the imposter phenomena. And what you note is that about 40% of physicians fall into this minimal imposter phenomena, but the remaining proportion are falling into this moderate, frequent, or intense imposter phenomena area, where almost 1 in 4 of physicians after we get done with training still have some of these beliefs that our success is undeserved and due to luck rather than all of our hard work, skill, and ability. And as your score on that scale moves from a more favorable to a less favorable end, you see that the mean emotional exhaustion score, one domain of burnout, begins to go up. Notably, on multivariate analysis, when we compared scores of US physicians on one of those items, specifically disappointment in my present accomplishments, to how workers in other fields outside of medicine scored on that item, physicians rated it much less favorably than workers in other fields. And I think for many outside of medicine, that's counterintuitive. They think physicians are highly trained, we work really hard, we engage in really meaningful work, make a difference in patients' lives. How could we be disappointed in our accomplishments relative to workers in other fields? But that's what the data show. And I think it's because both we hold ourselves to extremely high standards, and we often compare ourselves to our incredibly talented colleagues and are always having a sense of maybe we're not doing as well as others, even when that's actually not the case. And it suggests that we need systematic efforts to address some of the professional norms and perfectionistic attitudes that we partially bring with us, but that the training process in medicine often amplifies and strengthens if we want to really help mitigate this challenge. And that is related to this second dimension of self-compassion, or what we sometimes refer to as self-valuation. And as physicians, we're often incredibly compassionate with others, but often harsh, perfectionistic, and self-critical when we evaluate our own performance. In this study, my colleague Mickey Trockel looked at a sample of nearly 4,000 physicians in the US using this standardized scale to measure self-valuation or self-compassion. And here on the x-axis, higher scores are favorable. You see sort of a bell-shaped distribution in self-compassion scores with a little bit of a rightward skew. A distribution of scores. And what was notable is Mickey found that every 1 point more favorable score on this scale, the mean score for burnout decreased, such that among those with low self-compassion, almost all were scoring with high burnout. Those with high self-compassion, very few were scoring in the high range for burnout. And this is certainly not the only variable contributing to burnout, but it's an important one in the adjusted analysis, looking at the variables for which there was data in this sample. That self-valuation score explained about a quarter of variation in burnout. Now, here again, we would emphasize that self-valuation is not just a personal characteristic. We have professional norms and a professional culture that often promulgate lower levels of self-compassion. So we've considered some of the drivers, looking at both characteristics of the work environment, the training environment, as well as some of these qualities of our professional culture that contribute. How do we address this issue? I would emphasize here that we view this as an 80-20 problem. 80% of the solutions are characteristics of our organizations, our hospitals, our work and practice environment of our healthcare delivery system. That's where we should be spending the overwhelming majority of our efforts to address this issue. This is the area I usually focus on in my own leadership roles, as well as most of the lecturing that I do. But I know on today's call, most of the folks are hematology oncology fellows who don't necessarily control these levers. And so the question was, what can we do as individuals? We are not powerless. We are not victims. There are things we can do for ourselves. We should do these. We're going to consider some of these, but again, recognizing this should be advanced in concert with equal, actually even greater emphasis to address these issues on the left. When we think about driver dimensions, we often consider these 7 areas: workload and job demands, efficiency and resources, flexibility and control, meaning in work, optimizing our culture and the values alignment between our altruistic values as professionals and what our hospitals and systems are trying to advance, fostering community at work, and then fostering work-life integration. When we consider these in training, we often add these two additional dimensions. As residents fellows, we also have mistreatment experiences, which can be present when we're in practice, but are often more frequent or more intense when we're in training. And then our relationships with our faculty is another key dimension. And that when we think about these from the vantage point of residency or fellowship, that within each of these, there are some very specific things. And I'm just going to move through these somewhat quickly of what are examples of the types of things we're talking about when we consider workload and job demands, efficiency of resources, flexibility and control, meaning in work, values alignment, mistreatment, faculty relationships, work-life integration, community at work. When we consider each of these during the residency and fellowship training process. The next key point as we consider these different dimensions, all of which are important, so there's a lot to work on, that each of the hexagons is influenced by individual work unit. Perhaps here we're thinking about your residency or fellowship program, the hospital you work in, and then characteristics of the delivery system that are bigger than any one hospital. And so, again, one might think about efficiency. Not all fellows on the call today are equally efficient in the way we work. There might be characteristics of our efficiency that are influenced by the way our training program has structured our rotations, or once we're in the clinic, the way the clinic has structured its workflows. There are factors bigger than the clinic that might affect all fellows at our system, not just the hematology fellows in our one program. And then there are characteristics of the way care delivery is designed at the national level, or sometimes even bigger than that, the way payment is designed, a number of elements related to staffing and so forth that might be bigger than any one hospital and that affect efficiency. And so we just looked at one hexagon where there are variables influencing it at each of these levels. And oftentimes, again, not my focus today, but I just can't emphasize enough, this is where we need to be spending our time. Now, what can individuals do against that backdrop? And I think the first question that we always have to ask is, how well are we calibrating our own level of distress? And the answer is we don't always self-calibrate well. This is a study from a decade ago, 1,000 surgeons in the US. We asked them, how do you think your well-being compares to that of your peers, your colleagues nationally? And in this study, all the surgeons thought their well-being was at or above average. We always jokingly say there are no average surgeons in the United States. But this is not only true of surgeons. What this is true of is that we tend to believe that there's this narrative that these are challenging and demanding times for physicians or for fellows. I'm feeling distressed, but so is everybody else. I'm no different. And sometimes that's true, but we also promulgate that narrative even when we are starting to be different, when we are starting to have more severe distress than our peers. So in this study, amongst those scoring on a objective assessment at the extreme end of distress, a majority of those surgeons also said they thought their well-being was at or above average, illustrating this lack of self-calibration when we begin to experience distress. So in this study, this was an interactive survey. So after we asked them to self-assess, we actually had them complete the standardized instrument, and then we gave immediate feedback after they completed it as to here's how your score actually compares to your colleagues. Here's some of the things you might be at risk for based on your score. And then we asked them some additional questions after they got the feedback screen. And what was notable is once they had received that individualized feedback, how they answered the remaining questions about changes they intended to make to reduce burnout, reduce fatigue, foster work-life integration, and increase career satisfaction differed based on which feedback screen they received. And so what you'll recognize here is the continuum of behavioral change. Like with smoking, people can be at pre-contemplation to make a change, contemplation, planning, action, and then maintenance. And here, all of these surgeons are at pre-contemplation. My distress is no different than my colleagues. We give objective feedback. It helps them move to contemplation. I want to make some changes. I don't want to be below average in this domain. And then the question is, how do we help them move to planning, action, and maintenance to foster their own well-being? And this was sort of the next step we took from that study. We created an interactive version of that tool where people could say, create an anonymous account at Mayo Clinic, answer the very simple yes/no questions primarily, and then 2 other questions on meaning and work-life integration. And then as soon as they answered those, they would get immediate feedback. Here's how you actually score relative to your colleagues. And then teeing up, here's some resources. If you want to now plan about what changes could I make, you can select the area where you're considering making a change. If you click the fatigue button, here is what's sort of under that button. So here's Lottie doing a 3-minute video on what do we know about fatigue in physicians. And then there's the opportunity to look at resources, activities to foster progress, and key publications. And what's notable is you can then also trend yourself over time. I guess the trend curve you see here, that you can go back in and look at different time points and potentially make those changes. And so this is the tool that Mayo licensed, but what's notable is they licensed it if organizations want to use it as a way to assess at the organization and customize the tool by putting local resources. But any individual can actually use this for free. And there now are benchmarks for medical students, for residents, for fellows, for physicians in practice, for nurses, for pharmacists, for other groups. So if you want to download the app and set up your own just individual account at no charge, you can do that self-assessment and have access to the resources that are there. As we go then, after we've self-calibrated, how can we then begin to translate into action? And before I give you just a couple very brief suggestions, I do always like to dispel a couple myths that are common. And during training, we often have this first myth that things will get better when. And you just finish this sentence by saying, whatever is the next phase. When you're a resident, you say things will get better when I'm a fellow. When you're a fellow, you say things will get better when I'm in practice. If you're an assistant professor, you say things will get better when I get promoted to associate or to full professor. And what we have seen in some of our studies is residents often report this survival attitude, and that once we're in practice, and this was actually a study of oncologists, we often look forward to retirement as an essential wellness strategy. So things will get better when, it's not just when I finish residency, it's things will get better when I retire. And so it's this notion that we often don't believe that we can have a simultaneously meaningful and fulfilling personal and professional life. So we have to do things sequentially. We'll do work now, someday we'll retire, and we'll do the other things in life we care about. And the challenge with this myth is that things don't inherently get better with time. This is a study from about a decade ago in which we looked at US oncology fellows and practicing US oncologists using the same assessments. And some things did get better. Overall quality of life improved as you moved from fellowship into practice. Fatigue scores got a little better, but other things got more challenging. You know, satisfaction with work-life integration often became more challenging as you moved to maybe different stage of life, with more likely to have children, juggling your partner's career, career satisfaction actually got a little bit lower, even though it's still high. And so we often say things don't naturally get better, they get different. And we have to be intentional to make changes that will help us make progress. So we want to reject myth number one because it diminishes the relationships, hobbies, spiritual practices, self-care activities that remind us of our personal value and prevent us from making changes to integrate personal and professional responsibilities. The second myth is this notion of you can have it all, prestige, make the most money possible by working hard, have the perfect life outside the hospital with your significant other. And you know, the challenge here is that some of our professional goals are incompatible with personal goals. And if we try to pursue all of these things with equal emphasis simultaneously, we often are setting ourselves up for failure. And it prevents us from, in an intentional way, looking at an integrated priority list and making trade-offs. And so I'll spend the last few moments thinking about three things that we can do. I often think that related to this notion that we just talked about, we have to begin by identifying values. We have to reject that myth of delayed gratification. We have to think about what matters most in our personal and professional lives, and then integrate personal and professional values. I usually encourage you to take a moment the next time you're having an espresso on a day off to spend 15 or 20 minutes thinking about these questions to identify things that matter to you in your personal life and to take a few notes. And then, in addition to reflecting on these questions, to reflect on some questions about your professional values and things that matter to you professionally. And I often say, I don't know exactly how you answered the questions on the previous slide or how you may answer the questions here, but what I usually can say is probably true is that some of the goals you wrote on the previous slide or the things that matter to you on that previous slide and the things you answered on this slide are incompatible. And so our time, attention, and energy is limited. And when we get both of those lists together, we can begin to look at them holistically and think about how much professional achievement am I willing to trade off to have the relationship with my partner, my significant other, to do other things in my personal life that matter to me. The second thing that we need to reflect on is optimizing meaning in work. We derive a lot of meaning from our work. We've trained a long time to be hematologists, oncologists, and we care about that work a lot. In this study of 450 internal medicine specialists, we asked them what was the most meaningful aspect of their work, and then we looked at how they actually spent their time. And if you spent less than 20% of your professional work effort in that activity most meaningful to you, your burnout risk was high. So as you spent less than 5 to 10% time in that most meaningful area, burnout risk was in the 50 to 60% range. As you spent 10 to 20% time in that most meaningful area, burnout in the mid-30s. As you spent over 20% time in that activity most meaningful to you, burnout dips under 30%. That remaining 30% explained by work hours, call schedule, specialty, a variety of other characteristics. But did you or did you not have 20% was the most meaningful or largest factor in the multivariate predicting burnout? And what was maybe surprising and hopefully somewhat liberating is there was a threshold phenomena in this study that every 1% time less than 20 in that most meaningful activity, your burnout risk went up. But once you had 20% time in that most meaningful area, you had sort of saturated the burnout mitigation effect. And so I always say going above 20% might be good for professional fulfillment, but what's the part you must have to minimize burnout risk related to this principle? It's 20%. And that might make it more achievable. You know, what this activity is it varies a lot by individual. Maybe for you, it's, enrolling people in clinical trials and designing clinical trials. For some of you, it might be helping explain the illness to patients and supporting them as they go through the journey. For others, it might be transitions in care and quality of life and end-of-life care. It might be caring for a certain disease that you find meaningful and stimulating. And so once we know what that activity is for ourselves, we can determine how much time we're spending there, consider how many we might grow and expand it, and harness this principle. The final thing I'll share, we talked about identifying values and integrating them, optimizing meaning, and then we want to nurture our personal wellness activities. You know, we've all heard a lot about personal resilience, and the scholars in this field have done a tremendous work helping us understand the characteristics of human beings who go through intense and challenging circumstances and thrive despite those challenges. At the same time, others experience those challenges and struggle greatly. And these are the 10 qualities that these scientists have defined for us through their research. And the most important component to take away is that these are all skills that can be learned and strengthened. You're not born with an inherent amount and you can't ever expand it. These are skills we can learn and strengthen. And we should all learn and strengthen those things. But here I always like to emphasize that this is not the primary issue. A resilience deficit is not our problem. This is data from our 2017 national study of US physicians, in which we looked at US physicians, workers in other fields. We used a standardized resilience scale. And not surprisingly, physicians have higher resilience scores than workers in other fields. We couldn't have survived training were this not the case. More resilience is a good thing. When we look at the resilient population of physicians, as you move from a less favorable resilience score to a more favorable score, the burnout risk goes down. But here, the individuals with the highest possible resilience score, still about 30% of them were burned out. So I always say here, we're burning out 30% of the most resilient human beings on the planet in this current practice environment. So we won't resilience our way out of this problem. We should incorporate this as one strategy, and as individuals, we want to develop this, but we need to get back to system solutions. So I'll begin to wrap up by just coming back to where I started, that there are these individual things we can do to foster our professional fulfillment. We want to do more than just minimize burnout risk. We want to promote high professional fulfillment, meaning purpose in work. Each of us can work on things in this blue slice of the puzzle, but there are these two other slices. We color these red because we view them as Stanford's responsibility, and those relate to creating an organizational culture that maximizes leadership behavior, values alignment, giving people agency, purpose, meaning, and work, and support. And then we also have a whole host of other things related to the electronic health record and practice and workflow, teamwork, that also contribute to whether people are more or less likely to achieve high professional fulfillment. So with that, I'll stop here and thank you for giving me the chance to share some of these thoughts with you. And again, make the point that there are things we can do to not only eradicate work-related distress, but to promote meaning, purpose, and professional fulfillment. It's a two-sided coin. It requires action both at the practice environment, system, organization level, as well as advancing some of the things we can do for ourselves. And hopefully we can begin to do both. My email is here. Happy to take comments or questions if you send them my way. And thank you again.
What are your reactions to this?
Well,
Adela, go on.
I think this burnout project, for me, it's an amazing thing because to tell the truth, I am telling my point of view. I'm in Albania and we have a lot of products we miss. And the patients that we are going to treat, a lot of are not available every product prescribed, for example, in a protocol. And we are facing always this debate with with the patients and also the debate with the Ministry of Health. And this, it's carrying a lot of negative stress in me and also in my colleagues and the head of the clinic. So we are facing a lot of burnout right now, but nobody is going to tell this. I don't know why. And I was just checking around and seeing, well, it's only in Albania this, or it is also in other places, in other hematologists. And I found it out that it was, there were some studies around on this. But, well, I think she was going to start. I don't know, Com, you are at work until late, and I think you are still working now. This is heavy.
Yeah, but this is quite normal in France. I mean, we all went to that topic because I think we all think it's a matter of importance for all of us. It's not only just for ourselves, but like for the whole team and the whole teams of the hospital and the whole healthcare system at a higher level. We know that, and I think all over the world, the healthcare systems are facing many challenges, and particularly human challenges. And we can always say, okay, this is people's fault. They have to cope with that. I mean, they wanted to do it, so they have to deal with their issues. But it's very important to now think it collectively and to bring collective responses to these stressful environments that exist everywhere. Again, I think so. And it's not new, as Elizabeth was saying a bit before. And I think that we have now quite rich literature to help us in that direction. So this is why we have to now take this research further in hematology and to bring responses through with the help of the EHA for the whole community. I think it's very important.
I think it's, thank you for both of your comments. I think the notion of frustration is incredibly important because the levels of burnout can be as high in non-frontline specialties, what some people call the medical specialties of the dark side of the moon. And I think I in no way underestimate how difficult it must be for you in a country like Albania, where what you can offer patients who can see online what they could be getting is very difficult. But I think the notions of resilience that Professor Azoulay mentioned at the end are incredibly important, because you could spend 100% of GDP on healthcare and we still would not be immortal. So facing up to the fact that all of us are going to die one day, and how does each of us manage to put work for us in the right place? I think those kind of issues are incredibly important, because there's a lot of people who, not everybody who's got burnout goes off work. Some people have what's called in French présentéisme, being too much at the hospital, in this sort of, I'm drowning in work, but I've got to try and get on top of this. And by being more and more present in the hospital, I'll manage to cope with it. And that's not true. It's about finding a balance. And as my mother-in-law used to say to me, as a polite way of saying, you're not looking after my grandchildren enough, she'd say, why do you work so much? And I'd say, well, when I know why I'm working so hard, I will stop working as much. So, but I think the sort of notion of giving people the clues to protect yourself so that you can be a good professional. It's not about sitting at home and having saunas every morning. It's about finding some kind of emotional and spiritual stability to put work in its just space. And you can be helped with that. And I think that's where different institutions can work. I think it's incredibly variable, depending also on your team leadership. you can have two departments, one of whom has a leadership that is, let's say, adapted to what the team needs, and another which is totally inadapted. And you can give the same financial and time working load limits to the two teams, and the team workers in one will be reasonably okay, and the other will be dreadful. And then if the team leader has serious issues, then that's a big problem. I'm not saying it's any more important, but it just, because as Ellie said, it's infectious, so it affects the whole of the team.
Yeah,
So
and
it's definitely a problem for all of us.
Yeah, and as I was saying too, this is very person dependent, and then depending on your familial status, for example, if you have children, if you I don't know, anything, but depending on the sex, as I was saying, depending on many different things in our personal lives, it can affect our emotions at work. And so what is very challenging for us is to be able to bring a personal, individualized response and way to, at the same time, optimize people's work and protect them from burnout, while still respecting some kind of equity between the different members of the one same team. So
Yeah.
it's a whole challenge.
Anyway, I think we're coming to the end of our allotted 1 hour. I think this is obviously a sort of kickoff for what's going to be an ongoing project, and we'll be discussing it again once we've got the results of the survey. So I'll give both of you a final word, but I'd just like to thank you, Adela, for setting this all off, and you, Colm, for picking it up and running with it. So a last closing comment from each of you. Ladies first, Adela.
Well, tonight I feel so emotional, so I hardly find the words, but I have to thank you all, and mostly Colm, for everything he has done. Truly, I had the idea, but he has done the most. Thank you, Colm. And thank you all participants in this webinar. Thank you, Colm, again.
Thank you, Adela. I just felt encouraged by you and the whole team, the whole YoungEHA team that is with us, as well as the Young National Society ambassadors. And so this is a emotion that is brought up and helped by the EHA and the senior members that encourage us a lot in this way. So thank you all, and hopefully we'll see you in Madrid.
Yeah.
And we'll have a chat about burnout.
Yeah, why not?
And about nice things in hematology as well.
Too.
Yeah, of course.
Don't forget to come to the members area. And
Yeah, we'll be there.
And I'd just like to thank both of you. You are 40% of our membership, YoungEHA, so you're a very, very important part of our community, and you've enriched our society immeasurably since you've taken such a prominent role. So thank you for all of our wonderful young hematologists and our wonderful not so young hematologists.
Thank you.
Thank you,
Bye.
Professor. Have a nice evening.